Welcome everyone to tonight's fourth installment of FAAFP COVID-19 webinars. My name is Dr. Chris Scuderi, and I've had the pleasure of chairing the FAAFP's COVID-19 Task Force, which has been quarterbacking the FAAFP's efforts to assist Florida's family physicians and their staff in dealing with the COVID-19 crisis. Tonight's topic, an evidence-based primer about COVID-19 for family physicians, will address several critical issues, including updates on testing and screening, current guidelines on PPE, new standards for return to work, and an overview of medication efficacy for COVID-19 patients. Our presenter, Dr. Dan VanDurme, is a nationally recognized teacher and leader in family medicine, and certainly no stranger to FAAFP's dynamic educational offerings. Not to mention, he is an FAAFP past president in 1996. Dr. VanDurme has been with the FSU College of Medicine since 2004, where he served as the chair of the Department of Family Medicine and Rural Health for nearly 15 years. However, he was more recently named Chief Medical Officer for FSU's College of Medicine, where he oversees clinical operations for quality, safety, and coordination of services, acting as a liaison between the college and other healthcare entities. He is a leader for the development of their Integrated Primary Care and Behavioral Health Center, FSU Primary Health. If you were to ask him, he'd probably tell you it's a really cool job, as it allows him to have an impact not only as a teacher, but on the local Tallahassee community. Before we begin, a few housekeeping notes. As with all FAAFP webinars, participants will be in listen-only mode, but can type questions in the chat box that Dr. VanDurme can see, and will attempt to answer either during or at the end of his presentation. Also, stay tuned for more information regarding next week's topic on Thursday, April 23rd, Telemedicine 2.0, where we will revisit an incredibly important topic that will likely change the way we deliver primary care well past the COVID-19 crisis. Dr. VanDurme, welcome, and thank you for joining us tonight.
Thank you, Chris, and welcome to everyone else. I'm happy to be here and helping to share hopefully some good and useful information that helps us in the care of our patients. As you can see, and as we are all well aware, this information changes very, very rapidly. This presentation was last updated at about 1 o'clock this afternoon, and I'm sure some of the information has changed already. And just in the time we're talking, there'll probably be some new guideline that comes out. So I will encourage you repeatedly throughout this talk to use the cdc.gov as the best evidence-based source to be able to find what you should be doing for yourself, your staff, your patients, etc. And recognize that even as new as this coronavirus issue is, barely 5-6 months old since it first appeared in China, the CDC's research library already has over 45,000 articles. And many of these are tiny studies, a 1-2 person case report, et cetera, et cetera. So just keeping up on the information is pretty mind-boggling. So let's talk about some advances here to begin with. And no, I'm having a hard time. There we go. Let's get just a few definitions down pat as we start. We're talking here about evidence-based medicine, which many of you have heard me talk about before, and want to make sure that we're using that same term. I've heard it way too many times of saying, well, this is evidence-based and that's evidence-based, and it's based on very, very weak, very little evidence. So keep in mind that if we're going to talk evidence-based, we have to recognize that some evidence is better than others. What is the best research evidence say if we're going to use this? And we integrate that with our clinical practice and obviously with the care and values of our patients, what their expectations are. But it's not just blindly following the evidence. We really need to integrate all three of them. In terms of recognizing the levels of evidence as we go forward, the most widely used guidelines out there we'll call level 1 evidence to be something that involves multiple randomized control trials, ideally a systematic review with meta-analysis of a whole lot of randomized control trials. Level 2 is cohort, level 3 is case control. But when it comes to managing the situation with COVID, we really are relying a lot on level 5 evidence. There are a few case series that are out there that are small, a few cohort studies, very few, but a lot of it is expert opinion. What I'm trying to get people past is the what I call level 999 evidence of the anecdotal reports, what you overheard from somebody telling somebody else on Facebook or Walmart or whatever that way. So let's be mindful that just because you heard something might be done doesn't necessarily mean that it really fits evidence-based medicine, because that level of evidence is so weak. And again, this is a primer. This is meant to be a short introductory work. And I want to clarify also, we'll use terms that bounce back and forth. COVID-19 is the disease itself. The virus is called SARS-CoV or coronavirus type 2, as it is related to and kind of a cousin of some of the other ones that way. So here's our objectives. We're going to talk about testing and screening, some of the guidelines on the proper use of personal protective equipment, including the reuse of it, because this is in such short supply, standards for return to work, and then an update on some of the potential medications that are out there. This is not going to include, there's many sources for it, but we're not going to go through the epidemiology, pathophysiology, how the virus mutates, et cetera, et cetera. That will be other talks at other times, but certainly more than we have time for just this evening. I want to give you some very useful stuff. So this first slide here, I think, is probably your most useful one. I encourage you, as you download the slides, to save this, write this down, keep it up front at your clinics, et cetera. Look at the 800 or the 866, effectively an 800 number, for the 24/7 COVID-19 call center for the state of Florida, 866-799-6121, a number that you should have at your fingertips so you don't have to go digging it up later, keep it in your phone or whatever. The floridahealth.gov also has a number of information. If you want to know what the latest statistics are within your particular county or whatever, that's the place to go. The other thing I would encourage every one of our listeners to do is go to this website this evening, and you'll see that you can also get a drop down into the various counties. So if you click on that, you can go down and choose your county, and it will give you the the countywide epidemiology office, where you can report cases, where you can learn about availability of testing, et cetera, et cetera. So this really is a critical time. There's never been a more critical time in which we, as frontline first responding primary care physicians, need to stay closely engaged with the public health services to be able to make it through this pandemic. So let's start with talking about testing. As you can see in the slide there, and we're going to talk about it again, proper testing, that swab goes way back along the floor of the nose, all the way to the back. That's a nasopharyngeal swab, not just up the nose, but proper nasopharyngeal testing means that you've inserted that thing quite all the way back until you get to that nasopharynx area. So first thing I want to say about testing is there is no need to test everyone. First of all, we don't have the ability. There's just not enough tests that are out there. There's not enough availability in terms of sites, in terms of testing kits. I just learned that our local hospital, Tallahassee Memorial Hospital, which has been doing in-house testing for some time, is down to having only 50 in-house tests left. And they don't know when they're going to get more. Now, what we can do is we will send them out to LabCorp and Quest at an added expense and an added delay. So it doesn't mean people won't get tested, but we still have a crisis in not having enough testing materials available. The other reason not to test is that the majority of cases, 4 out of 5 cases, are mild. And we need to remind our patients of that regularly, that yes, it's scary and yes, it can kill, but the majority of cases are very mild. We need to encourage patients who think they might be sick, say, well, I've got a little bit of a fever and a little bit of a cough, just stay home. We don't have to, in the vast majority of those cases, test you just to see. And it's fair to be able to say to the patients that if they think they might have COVID, they should follow the guidelines. So on the left of the slide, what you'll see is the front and back of a 2-page handout. Every piece of information that you get from the CDC and the Florida Department of Health, I strongly encourage people to take careful note of the date. It's printed down there at the bottom. I blew it up there. This was effective as of April the 2nd. because another one may come out next week with other information. And you want to make sure that you can easily find out whether you're giving the most accurate and up-to-date information. The link is embedded in there as well. Here at FSU Primary Health, we just started today to print these up and hand one to every single one of our patients to say, hang on to this piece of paper, because if you get sick down the road, if a loved one gets sick in a few weeks and you think you might have COVID, you've got a good reference place to be able to go to. Keep this piece of paper on your refrigerator or bulletin board or whatever at home, and would encourage others to do the same. It's got some great information on it, stuff that we all know, but it puts it all together in a nice front and back of a single sheet of paper for our patients. The newest guidelines for who should be tested and how they get prioritized came out on March 24th from the CDC and March 28th with a slight variation here from the Florida Department of Health. So again, this is available. You can see the link down below. Would encourage you to have this posted prominently in your office so that you don't have to go looking for it. And again, pay attention to the date so that if a new guideline comes out on April the 17th, you can replace the one from March 28th with the newest guideline. So it breaks into priorities. We're going to talk about those in just a second. And it talks about how that testing gets done. That one from the Florida Department of Health is just a modification of this one. This is the one that the CDC put out on March the 24th, which also breaks it down into these priority groups, priority 1, 2, and 3, and then who is in a non-priority group. So again, my recommendation is post one or both of them in your office, mark the date on it prominently, be ready to update. And my strong recommendation is every one of us out here on the front line should be going to the CDC website at least once a week and looking at some of these key documents and say, is there something new that came out in the past week as far as the testing, the screening, the return to work guidelines, et cetera, et cetera. So why do we have these testing priorities? Well, one key issue to remind patients of is that they get a negative test today doesn't mean they're not going to turn positive tomorrow. So I'm sure many of you have, like me, had patients who say, well, I want to be checked just to be sure. No, I'm feeling pretty good. I'm not feeling that bad there, but can't I get a test just to know? And the feedback should be, no, it's not doing you or anybody else any good to know that today you don't have the coronavirus, because tomorrow is when it may turn positive, or next week. Community-wide testing, community-wide screening is going to be critically important if we're ever really going to understand this virus, if we're going to understand about how asymptomatic spread occurs, if we're ever going to understand a true case fatality rate, because we really don't know what the case fatality rate is for this, because we don't know the denominator. We don't know how many people are infected. We know how many show up with symptoms, and we know of those that are tested and are positive, what the fatality rate is for that, but that doesn't tell us about the true picture of the disease. Bottom line though, with our lack of testing ability, it's months away. Other key aspect to the priorities is to recognize that some people do need to get to the front of the line. They can get expedited testing through some of the state labs. There's one now in Jacksonville, Miami, and Tampa, if needed. And you should find out, again, find your local county health department epidemiology office so that you keep that information quite handy. So who do we test? This is the guidelines. Who is symptomatic? The big three criteria for the CDC is fever and or acute respiratory symptoms, cough, shortness of breath. Those are the biggies. You don't have to have all three. The presence of just one in a hospitalized patient or a healthcare worker is enough to be able to do the testing. We know there are a number of other symptoms that have been increasingly discussed out there. The smell and taste dysfunction seems to be occurring in about 80% of people. Some who get a loss of the sense of smell or a loss of the sense of taste, others who will get abnormal smells and tastes, etc. Headaches, fatigue, diarrhea, etc., all can occur with it as well, each happening in about 50% of the cases, but those aren't the big three. Fever, cough, and shortness of breath are the big three. So if somebody is symptomatic and they fall into priority 1 category, then these are hospitalized patients and a healthcare facility worker. They fall into category 1. We'll talk about what we do with them in just a second. Priority 2 starts to get to those that are also at highest risk of complication. These need to be rapidly identified and triaged. So if they are in a long-term care facility and they've got symptoms, over the age of 65, they have underlying conditions with symptoms. Big ones are heart, lung, and liver disease, renal disease to the point of being on dialysis, not mild chronic renal failure, diabetics, those with an impaired immune system, and the severely obese, so the BMI greater than 40. There are certainly many other underlying conditions that may make them worse. Smokers get worse cases, those with other problems will, but the CDC guidelines list these as being the key underlying conditions with symptoms. And then finally, the first responders. So the idea is if somebody is in a priority 1 or 2 category, they need to be tested in a way that you can get a very rapid turnaround of that test result. These can't be the ones that you have to wait 7 to 10 days for results. And here in Tallahassee, a few weeks ago, 8 and 10 days was a common turnaround time. Now we've gotten it down to about 3 days for most of the testing that's done in our area. But you need a rapid turnaround. So you need to know what can be tested at your local health facility. Is your hospital doing the testing and can get the testing done through there so that you'll get the result back within 24 hours or so. Find out from your local labs and talk to them. What is your current backlog? Obviously, some counties are hit harder, much harder than others. Some counties have a very robust with multiple private labs and others don't. But you need to know what their turnaround time is before you just send it off there and say, now I'm sitting here waiting for a week or longer before the test results come back. If it's a healthcare worker, they can get them done through the Florida Bureau of Public Health Labs. You can see the phone numbers there on the slide. Call the one that's closest to you, and they will give you the guidance on shipping, about how you have to collect it in viral transport media. Make sure that you ship it with insulated cold packs, et cetera, and they're getting their results back within a 24 to 48 hours. But that's why these are priority 1 and 2, because we can't afford to simply wait a week or more for results. Priority 3 starts getting into the issue of as the resources allow, and we have to think about resources broadly defined. Resources of how many test kits we have, how overfull or not your local hospital may be, how many physicians, how many urgent care offices, et cetera, are in your area. Do you have drive-through testing capability, as is popping up in a number of counties, but certainly not all of them, not even most of them. So in those cases, then as the resources allow, it starts to say, yes, it starts to become reasonable to test other people to try to decrease your community spread and ensure the health of essential workers. So these become those other infrastructure workers that have symptoms, people who don't meet the above criteria, but they still have symptoms. So they've got a fever and a cough, but they're under the age of 65, they don't have other comorbidities, et cetera. Or the symptoms are fairly mild, but you know that you are an area with high numbers of COVID hospitalizations. So as of this morning, as you can see down the bottom, the Miami area, if you had Palm Beach, Broward, and Miami-Dade counties, as of this morning, they had over 13,000 cases, whereas in the Tampa Bay area, adding up Hillsborough and Pinellas County, obviously the overall population is lower as well, but they've only got 1,300 cases. So knowing what's going on in your area is important. Again, you can get that from floridahealth.gov. So how do we get these specimens? Got to remember that the actual collection is going to generate aerosols. People are going to cough, people are going to sneeze, people are going to gag when the specimen is collected correctly. So you need to warn the patient that this is going to be a deep swab. If you go gentle, if you go too gentle, if you go too quickly in and out, if you don't get a good enough specimen from back far enough, then you're going to run the risk of false negative results. And that's true with anything. An inadequate specimen on a strep throat test will give you a false negative. The preferred testing, very clearly, preferred is that single nasopharyngeal swab. Early on, they were doing some 2 swabs, go down on each side of the nostril, no longer felt to be necessary. A single swab is appropriate. If that cannot be done because of the patient's anatomy, because of blockages, et cetera, then an oral pharyngeal specimen collected by a healthcare personnel is considered to be second choice, but acceptable. A mid-turbinate swab that can be collected by the patient themselves, so that you'll see this on-site self-collection for both a nasal mid-turbinate and an anterior nares swabbing. So the idea is that this should be witnessed by a healthcare professional who's making sure that they put the swab in far enough, they kept it in long enough, they swirled it around, etc. And then finally is the nasopharyngeal wash or aspirate. The technique for this is the same as is for an influenza swab. So if you're doing in-office rapid flu testing, it's the same technique. But what I've found in talking to other docs and a number of medical assistants, they have not been getting good nasopharyngeal swabs when they're doing the flu testing either, going in just quick up to the front of the nose. So you'll see the links below, and you can print out a little handout for your staff or for yourself as you're collecting some of these swabs that way. Let's talk about some of the upcoming testing options. Abbott has got one that's gotten a whole lot of press about using PCR testing to try to find the virus. It's CLIA waived, office-based. You can get results very, very quickly. And people are saying, oh, when can I get my test? When can I get my test? The bottom line is there's not enough of these available either. They're now shipping them to hospitals and hotspots, but the expectations for being out to regular doctors' offices, for most of us, is maybe they will have enough to ship in June and July. It's an expensive test. The machine runs about $8,000 as I've tried to look and price it in a number of different places. And each testing kit runs about $50. So we're not there yet for it. The other testing that's getting a lot of press is antibody testing. Do not go there, do not go there, do not go there. The problem is that the FDA relaxed the rules in the midst of this emergency so that companies can sell devices without proving validation data. So many of these are being made all over the place, are being made in China without having good validation for how accurate they are. Because they're antibody testing, they don't determine the active infection, so it's not helping me out to say what this person is sick with now. It's only going to be good in a convalescent sort of a state. There's well-proven cross-reactivity with other coronaviruses. As we know, about 30% of upper respiratory infections are caused by other coronaviruses that are very benign, and some of those can turn this antibody testing positive. So you don't want to give somebody the false impression that, oh, you're great, you've got the antibodies, you're immune to this coronavirus, when in fact they are just showing evidence of their prior infection with another type of coronavirus. And perhaps most importantly, we just don't know yet how long the protection will be from the antibodies and what degree of protection will result. So until we get some long-term serological studies to find out how much antibody for how long provides how much protection, and we watch how this virus might mutate, it's just not a good way to go. So we got to talk our patients out of trying to go that way. All right, marching along. PPE, I love this picture from a hospital where everybody gowned up, put pictures of themselves on their gowns to kind of add a little bit of humanity to the isolation part. So when it comes to the guidelines for PPE, again, you'll see the link. There's the example of it for the proper procedure for putting on and taking off, or as they call it, donning and doffing your personal protective equipment. Keep it as we do. We keep a copy of this handout sitting right next to the table where we've got our gowns and our masks and our face shields, et cetera, et cetera. It is very helpful, and many will say it is essential to have an assistant who stands with you, next to you, while you're donning your equipment, who's walking you through and reminding you, okay, put on your gown first, now use hand sanitizer, now put on your face shield, now put on your gloves, and walk you through the back part of it as well. They can also reach around behind and tie off the isolation gown, et cetera, as needed. As we know, there are national shortages of many of the PPE equipment that we need. And so the CDC has now put out some guidelines very recently about how to deal with this critical shortage as we move from a conventional supply to contingency to a contingency capacity to finally a crisis capacity. And it varies from literally hospital to hospital. You're getting overwhelmed and you're down to having just a few of these, then in an absolute crisis area, we know that it's the 5th choice on that list, but you use a cloth patient gown for an isolation gown if you need to. But they'll walk you through a lot of those at that website. One of the things that can be done is to reuse face masks, whether these are procedural masks or N95 masks. The CDC, again, also has some very good information about the three types of disinfectant that they recommend: vaporous hydrogen peroxide, ultraviolet irradiation, or moist heat as the most promising decontamination methods. Some hospitals have started using the vaporous hydrogen peroxide. What we've done here, and I know a number of other docs have, is started using this moist heat method. To the left of the slide is a handout that you can download from the handouts on this slide, and we can email it out to you as well, that walks through the process of how one goes through decontaminating and reusing masks in the face of a shortage. And there's a version here that's got a whole lot of details with quotes from the CDC and the references of where this came from out of the International Society of Respiratory Protection and other places. So that one's created for the docs who want to use it. I also created one that was simplified and got rid of the references that you can hand to your patients. So if they want to know how should they clean and make sure that their cloth masks are in fact appropriately decontaminated, this is a relatively easy way to do it with materials that many people probably have right in their homes. And here's the basics. Pot of boiling water, put the masks in a metal strainer or colander that suspends over that. Put the pot on to boil as the water boils underneath. The temperature underneath or within that colander should easily exceed 60 degrees centigrade. When I tested it here, ours got to 80 degrees centigrade. And you hold it over that boiling water for 15 to 30 minutes and let them cool off. And that has been shown, again, according to the CDC, as being completely effective at killing other viruses. They haven't done the testing on coronavirus, but it kills all the other viruses they have tested this on so far. And returning to work. One of my favorite slides here. Those meetings could have been emails. So the updated guidelines as of not quite 2 weeks ago is that there are 2 strategies for what to say to our patients about when they can return to work after they have been found to be positive. One is this non-test based category, which means we just use the time since the illness or recovery, and there's a test-based strategy. So they should have gone at least 3 days, and the key to tell your patients is this is complete resolution of the fever without the use of Tylenol or other medications, and their respiratory symptoms have improved, and it has been at least 7 days since the first symptoms. So that's option number 1 for general population that way. If you have robust ability to do local testing, then what is recommended is, again, the resolution of the fever without fever-reducing medicines, improvement of respiratory symptoms, and then you get 2 consecutive nasopharyngeal swabs greater than 24 hours apart. So if you've got 2 negative specimens, then you can send them back to work and say, yes, to the best of our knowledge, you're no longer contagious. But that's only if you've got a good, robust local supply of testing. For healthcare workers, that test-based strategy is the preferred method. So that's the only difference between these 2. Is that for the non-healthcare worker, they're both considered equally acceptable methods. If it's a healthcare worker, they want to make sure you've done the same thing. No fever without fever-reducing medicines, respiratory symptoms are better, and they've had 2 consecutive nasopharyngeal swabs. Only if it's not possible, then you can use the same time-based strategy. At least 3 days without fever, improved respiratory symptoms, and 7 days since it has passed. And finally, the asymptomatic one, somebody who was screened and had tested positive without symptoms, the recommendation is that you wait a full 10 days since the date of the first diagnostic test, assuming they've been asymptomatic for that entire 10-day period. When healthcare professionals return to work or healthcare personnel return to work, recommendation is to wear a mask at all times when in the facility, not just during patient care, excuse me, but when you're walking past other coworkers, et cetera, that the mask be worn at all times until 14 days after the illness onset, or all symptoms are completely resolved, again, without meds, whichever is longer. And then obviously being very careful with severely immunocompromised patients and continue to self-monitor for symptoms. And finally, let's talk a little bit about the meds and the treatment. And the bottom line is what's the problem for these people and what's killing them and causing all the hospitalizations is they're getting a viral pneumonia with ARDS. And we've been taking care of that stuff for years. The fundamentals remain unchanged. It's supportive care, giving them the oxygen they need, from low flow nasal cannula to high flow to progressing all the way to mechanical ventilation as needed, managing the other comorbidities, et cetera. There's a few drugs that are out there that have been given FDA emergency use authorization. It's important to understand and to tell our patients that it does not mean, it's not FDA approved. To be FDA approved, that means it has to be shown safe and effective. These have not been shown that way. The EUA means that in the case of an emergency, it's okay to try this, but it has not been proven to be safe or effective. And JAMA article that just came out 3 days ago said very clearly in bold letters, there is no proven effective therapies for this virus at this time. But we've got a few that are getting a lot of buzz. The remdesivir, hydroxychloroquine, plasma exchange, et cetera. So let's touch on those for just a couple minutes. Remdesivir works by inhibiting the polymerase in the coronavirus, so it stops its replication. Been around for a number of years, first used on Ebola. It has been used successfully with other coronaviruses like MERS and SARS. And there's a number of studies underway right now. So we're really expecting to get some good answers on this over the course of the next few weeks. Very early studies say it does look promising, but it is not yet FDA approved. It's only available in terms of enrollment in clinical trials, some of the expanded access options, and compassionate use just for the kids under 18 and for pregnant women. Hydroxychloroquine has gotten way too much press, in my opinion, on the basis of some very, very weak data. So some very limited anecdotal reports, some very small uncontrolled trials. They were not placebo controlled. They said, oh, look, we gave them hydroxychloroquine and they got better. We gave them hydroxychloroquine with azithromycin and they got better. And we don't know, they may have gotten better anyway. And we gave it to a lot of them and they died. And people say, oh, well, they may have died anyway. So the problem is that we know these show some in vitro activity in terms of how they block the viral entrance into the cell, and they have immunomodulatory effects. That's why we use them for stuff like rheumatoid arthritis and lupus. But bottom line is there's no data. These have not been shown to be safe and effective. Number of studies are underway, including a very large one that just started up at Vanderbilt University, that they're really going to, what looks to be a very well-designed, blinded, randomized controlled trial of hydroxychloroquine with placebo. And these drugs are not benign. They have very serious side effects with liver and renal damage, cardiac arrhythmias, and other problems. Convalescent plasma shows some promise, and at least it did not show any harms. So it's been used again in other small studies with MERS and SARS over the years in small case series. So, level 4 evidence, if you will, shows some benefits for COVID patients, and again, no real harms. A few weeks ago, the FDA released guidance for how you can get investigational new drug application and screening guidelines. There's, again, a number of studies underway, but bottom line is we just don't know yet in terms of whether this can improve effectiveness. If you want, this image is from the JAMA article that is referenced a couple of slides ago that shows 6 or 8 or 10 different drugs and where they seem to work in terms of inhibiting the viral entry into the cell or the RNA polymerase that's involved, et cetera, et cetera. But again, this is all just under investigation. No drug has yet been proven to be effective. A couple other things on meds is that ARBs and ACE inhibitors have gotten a lot of buzz out there on the basis of some inappropriate comments from people, highly theoretical. The CDC, the Heart Association, the American College of Cardiology, all of them say, continue keeping your patients on these meds. There's no good evidence of a link between these and either contracting COVID or if you get COVID, having it to be a worse illness. Ibuprofen is another one. I had a patient like that that I did a telehealth visit with 2 days ago and was miserable with his arthritis that had been well controlled with ibuprofen because he was told that he shouldn't take it because it might lead to him getting coronavirus or getting a bad case of it. Again, no good evidence to support that. Unfortunately, a tweet or a comment made by the French health minister, the World Health Organization has specifically stated they do not recommend avoiding ibuprofen and other NSAIDs at this time. Again, we may change that a month from now when some better studies show us otherwise. So my few closing comments, we'll take some questions, is send your patients and yourself to cdc.gov. Help combat some of the tons of misinformation that's out there, the outright scams, the crap that's out there on Facebook and other places. Tell patients that, yeah, this is scary because we're not certain about it, but it doesn't mean that we're clueless. We are learning more and more about this on a daily basis. And every day that we can delay this with social distancing means we'll be that much closer to knowing what drugs really do work, what good screening rates actually should, or what good case fatality rate data we might actually really know about how bad this disease is. So there's a lot we don't know, but we do know a fair amount. So help reassure patients that way. Keep the information at your fingertips. Keep revisiting cdc.gov on a weekly basis. And let people know that staying at home does not mean that you are retreating from the world. It means you are being a healthcare hero. So when you're staying home and you're washing your hands and all that sort of thing, every patient can save lives by keeping themselves appropriately physically distanced and helping us get through this. So with that, I think there you go. A couple of general references there from CDC and the World Health Organization. And with that, I'm happy to take some questions.
Excellent. Thank you, Dr. VanDurme, for an amazing presentation and a great review for us family physicians. Just a reminder, if you want to use the chat function, you can ask questions. And I have a couple, Dr. VanDurme, that I will ask you. One of the first is, what is the latest tally for incidence of illness and deaths in Florida and South Florida? And I could take this or do you want me to look that up while we were going, or do you want to answer that?
I don't know that off the top of my head. Yes, healthcare workers are dying from this, but I don't know the latest stats. If you can find that, Chris, that would be great.
Excellent. So I have for Florida, the total cases currently as of about 20 minutes ago is 23,340 cases with a total of 633 deaths. And specifically in South Florida, Miami-Dade has 8,326 cases with 183 deaths. Broward has 3,466 cases with 101 deaths, and Palm Beach County has 1,867 cases with 112 deaths. So that's that data. Let's go. Number two is, why should we not test as many as possible, like in South Korea? Why should the limited testing availability determine the practice of good medicine?
It's simply a reality. It shouldn't. In an ideal world, we would have been ramping up testing capability months ago, like South Korea did. They saw it coming and they kicked their manufacturing places into high gear, making tons of viral transport media and testing kits. We did not do so. And so you're right. The lack of testing is preventing us from practicing good medicine. It's a sad reality, but you're right. If we had an ideal world, we'd have plenty of tests and we would know a whole lot more. We just don't have the test kits.
Thank you. And the next question is, are you seeing an active cohort of patients, and are you discouraging in-person patient visits?
So yes, we are still, and I know a number of docs are, we are still seeing patients in our facility. I'm still seeing patients on a regular basis. We are encouraging telehealth visit if it can be remotely reasonable. As we know, there are certain things that say, when you've got belly pain, I need to be able to see you and lay hands on that belly to be able to figure out what's going on with it. So I know some doctors' offices have closed completely, certainly in the Tallahassee area. But to my knowledge, all of the primary care offices are still open, still seeing some patients while pushing towards telehealth as much as we reasonably can.
Thank you. The next question is, I treat a patient suffering from COPD and CAD, and his wife is concerned that she may be an asymptomatic carrier. She wants to be tested, but she cannot be tested because her insurance denies testing. What shall I do?
That's a real hard one. That's a great question. What I would say is, at this point, depending on what the availability is in your area for testing, she has the options of, does she want to pay for it herself if her insurance will deny it? And it can be done through a private lab to give her hopefully some degree of peace of mind. But my suggestion to her would be, I said, I would not test you. You should still wash your hands carefully as you're caring for your husband. But I get back to my comment much earlier, and that is, if I test you and you are negative today, then it doesn't mean that it's going to help us in terms of how you manage things tomorrow. And if you're very concerned for now, then say, yes, I'm going to practice reasonable social distancing within my house, of saying, I'm going to be real careful and wash my hands, and I'm not going to kiss my husband on the lips for a few weeks, and do some of those. And I know people that are, they've moved husbands and wives where one is at, has many more comorbidities. They decided to play it safe and sleep in separate bedrooms for now. It's all how you manage that fear and that uncertainty.
Thank you. The next question is, how can we perform a good nasopharyngeal swab without having access to PPE, including face shield? It's a high-risk procedure without PPE.
And to me, the answer would be don't. If you don't have PPE, then I would not do a nasopharyngeal swab. I would find a way, send them to some place where they do have it, and say, if you don't have a face shield and you don't have a mask and you don't have the ability to protect yourself, you're right. Doing a proper nasopharyngeal swab is a high-risk activity. And if you've got the ability to not do it and send them elsewhere, then send them elsewhere. Alternatively, say they've got nowhere else to go, and I'm trying to do what I can as their family doc. On the CDC's slide, which talks about the crisis contingency mode, they talk about using things like homemade plastic shields, using cloth covering over your mouth, a double layer of cloth covering, et cetera, et cetera. But again, those are a distant second, third choice when you're putting yourself really in harm's way to get a proper nasopharyngeal swab.
Thank you. And so the next question, you have a fan club, so it says you're the best, Dr. VanDurme. And then it is, what is the estimated sensitivity of the MB-PCR swab for coronavirus testing? It seems like we're encountering lots of clinical COVID who end up having a negative test.
Great question that I wish we had the answer to. I've been asking that question myself as well. I've participated on way too many webinars and phone calls with people from the CMS to the CDC to the state, et cetera, and no one seems to be able to have good, reliable data on the sensitivity and specificity of the tests. They seem to be better than 90%, but they're highly dependent on how good a swab that you get. Again, the quick in and out just from the anterior nares, you're going to get a lot of false negatives from that. The false positive rate is low, but we really don't have good, accurate data. The very weak data is it's running well over 90%. But beyond that, we can't say for sure. I've asked that question myself several times.
And I think that's one everyone wants to know. So, question number 8 is, limited reuse, including mass washing, is a symptom of a totally broken healthcare system. In Israel, all healthcare personnel are being supplied with PPE by the Ministry of Health with orders from equipment from China. How can we force hospitals to supply us with necessary PPE?
A great question. You can't, because the hospitals are short. And that's part of the problem. I mean, many of the hospitals, they don't have enough PPE for their own people. Without going too much onto a political side rail, I will say that when people talk about going back to normal, I'm hoping this shows a whole lot of us that we should not go back to normal. Our healthcare system and the intersection between public health and how we plan for pandemics and how we manage our supplies, et cetera, should never go back to the way they were a year ago. Because you're right, other countries said, we need to take care of this. We need to get the masks. We will manufacture them. We will get them to the people who need them. And what we have in the US is, no, it's up to the states. And the states have said, no, it's up to the counties. And the counties have said, no, it's up to the hospitals. And I've sat through too many of those webinars as well, that there is no coordinated effort. And there is no way to force them, and certainly no way to force them to give what they don't have to give. because many hospitals are hurting as well. They don't have masks to share with us on the front lines as family docs.
Thank you. The next question is on using a non-test-based return to work criteria. Is there some concern with that, as there's been some studies saying that the virus particles can be found as long as 37 days after symptoms are gone?
I have seen some of those and have heard that that can be found, the testing can be found that late. And is there a concern with it? Yes. Again, the best expert opinion that we have is we think that those are rare and unusual cases, not enough to keep everybody home from work for 37 days. That's partly why we want to make sure that they are symptom free, that they're no longer coughing, they're no longer going to be spewing aerosols around in terms of if they still have any virus left in them. That's why even when they return to work, everyone should be practicing careful treatment and cleaning of their work site. The handout that's, I don't know, about the fourth or fifth slide in, that talks about what to do has great information about using disinfectant wipes on your computer, on your desktop, on the telephone that you use. And I would continue to recommend that strongly for anyone who goes back to work, even if they've matched the time criteria. They've been symptom-free for days, they've had no fever, et cetera. They should still continue to treat their surfaces, especially any shared surfaces at work, as though they may be infected or may contain virus.
Thank you. And that looks like the majority of the questions that we have. One second here, Dr. VanDurme. I appreciate everything that you've done tonight. It's a fantastic webinar. I think that there's just been tremendous information that can help family physicians around the state of Florida. If there's any issues with any questions that come up, we can answer them at a later time too, if you continue to use the chat feature. Just want to thank you for just an amazing presentation that I think will help our members now and into the future as we start to understand what the new normal will look like. Also, I'd like to thank all participants tonight for joining us, and not to forget to tune in next week, live at 8 p.m. next Thursday for Telemedicine 2.0, our second installment on a very important topic. Finally, all FAAFP webinars will be located on the FAAFP website by logging into www.faafp.org. So just want to encourage everybody out there to be well, stay healthy, and have a great night. But most importantly, want to thank you, Dr. VanDurme, for an amazing presentation. Thank you so much for just giving us, sharing this important information with us at this critical time.
My pleasure. Take care, everyone. Take care of yourselves, take care of your loved ones, and keep socially connecting with people, even if you can't physically connect with them.
Excellent. Thank you. We'll see everybody next Thursday night. Thank you.
Bye-bye.